Hello there. So now let's move ahead with gastroenterology. So in a new scenario here, we have a 41-year-old man who has had a liver biopsy as part of investigations for abnormal liver function tests. The pathology report states special stains demonstrating the presence of a very large amount of iron pigment within hepatocytes. What single condition is identified by the pathology report here? So the pathology report here is to be studied, and it is indicating towards hemochromatosis. In hemochromatosis, characteristically the iron is found predominantly in periportal distribution, that is SNR zone 1 within the hepatic lobule, with virtually all iron deposited in the parenchymal hepatocytes and none present in Kupffer cells. By contrast, iron overload in case of hemocytosis causes accumulation of iron granules predominantly in the Kupffer cells and more in the central area rather than peripheral hepatocytes. Since the question gives the pathology report of large amount of iron pigment in hepatocytes rather than Kupffer cells, the diagnosis here will be hemochromatosis. So this is what we have to keep in mind, that in hemochromatosis, for iron storage there is peripheral distribution. In SNR zone it will be stored. Iron is predominantly stored or found in the peripheral zone. There is peripheral distribution. Within the SNR zone 1 it is found more in the hepatocytes and none in the Kupffer cells, whereas in hemocytosis it is found mainly in the Kupffer cells and not much in the hepatocytes, and there will be central distribution in hemocytosis. So this is the basic difference here. In hemochromatosis, iron is found predominantly in peripheral distribution or periportal distribution, and it is found mainly within the parenchymal hepatocytes and none in Kupffer cells, whereas in contrast, in hemocytosis, there is accumulation of iron mainly or predominantly in the Kupffer cells, not much in the hepatocytes, and it is more likely to have central distribution. It is more predominantly stored in the central area rather than peripheral hepatocytes. So this is the main difference here. So because in the question it says iron pigment within hepatocytes, not in Kupffer cells, so it is hemochromatosis. Now let's move ahead. A 23-year-old man complains of difficulty swallowing solid food over the last 2 years. It is intermittent, has an episode once every few days. The chest pain associated with dysphagia is present. Occasionally, he would have regurgitation. He has recurrent chest infections, no history of weight loss. What is the single most appropriate initial investigation? So, as we know, in case of dysphagia, always endoscopy is the most suitable initial investigation. Now we know that this is a very controversial question. The top two choices would be endoscopy and barium swallow. It is a complicated one, and that's why we need to go a little into the detail. The differentials which need to be considered here are diffuse esophageal spasm, achalasia, scleroderma, esophageal ring, esophageal web, and esophageal cancer. The description in the question best fits diffuse esophageal spasm, except that there is usual dysphagia to both solids and liquids. The question only includes dysphagia to solids without mentioning liquids. As the patient is young, cancer is unlikely, so understandably many candidates would pick up barium swallow rather than an endoscopy. A barium swallow is less invasive, can be used to diagnose conditions like diffuse esophageal spasm, eclasia. However, it is an incorrect option. Patients with dysphagia, despite their age, should undergo endoscopy with esophageal biopsies so as to rule out and treat mucosal and structural disorders first. Barium swallow is considered where endoscopy is not possible or if endoscopy is normal but a structural abnormality is still suspected. So we have always studied in even medical school that in achalasia and diffuse esophageal spasm, it can be seen in barium swallow and the gold standard is manometry. But now it is outdated. Endoscopy is now a must do first for any patients with dysphagia prior to proceeding to a barium swallow or manometry. We are aware that reliable sources would state that a barium swallow would be reasonable to perform first. However, there has been an intense research on this. So, even according to NICE guidelines, where patients with dysphagia, irrelevant of age, should have an endoscopy. So, even according to NICE guidelines, in case of dysphagia irrelevant of age, always the patient should have an endoscopy. So, in summary, dysphagia plus initial investigation, it should be endoscopy with exceptions of suspicion of a pharyngeal pouch because there is a risk of perforation in that case. Dysphagia plus diffuse esophageal spasm or achalasia plus most appropriate investigation, then it would be barium swallow or manometry.